topic today is lesser known and off-label ways to manage migraine. These are things that are certainly not what your neurologist or headache specialist would consider as a first-line medicine, as a 50th line medicine, maybe. These are oftentimes used in combination with more traditional treatments. And just a little bit of a background about me. I am a New York City-based neurologist and headache specialist. I worked at NYU up until just a month ago when I became full-time at NeuroHealth. I also am an adjunct professor and completed my headache fellowship at the Jefferson Headache Center, which is the largest headache center in the United States. And just a few years ago, I was an emerging leader of the American Headache Society. So all I do really is headache, and I very much focus on, obviously standard treatments, but also sometimes things that are coming out of left field. So who are we thinking about when we recommend some of these off-label, lesser-known kinds of treatments? People who have worsening migraine, and we think about worsening migraine, very difficult to treat migraine, in one of maybe two different kinds of buckets. One is an individual migraine attack that lasts a very long amount of time, and the other is months and months of high frequency headache attacks. And these are really very different things. Status migrainosis, the focus is to stop an individual attack, whereas chronic migraine, the focus really is preventive treatment. And in general, if you were to come to your doctor and you were doing okay-ish before and now you're not, your doctor is going to want to think about, why are things worse? Migraine definitely can worsen sometimes spontaneously for many people, but not necessarily for everybody. And it is very important, first and foremost, to make sure that there isn't what we call a secondary cause to your worsening headache. For instance, terrible things can also sometimes happen, and you want to make sure that there isn't, something systemic. So SNOOP is an acronym that neurologists have used for years now that help us remember, signs and symptoms that are red flags. So could there be something else, something systemic that could be causing it if you're experiencing other systemic symptoms? So in other words, if you're also experiencing, unexplained weight loss and night sweats, or some kind of infection, or if there's, an autoimmune component to it, if there in your history, if you have an immunocompromised state, either from medications or from, based on your medical history, if there are other neurologic signs or symptoms we have to think about, maybe there's some other part of your central nervous system that's actually affected, and it's not just your migraine getting worse. We always worry if there's rapid onset, or if it's kind of a new headache and you're older than 50. And if there's any change, the P stands for a couple of things: positionality, if there's a change in pregnancy, or importantly also, if there's a change with, there's a change that's associated, that's different than your prior headaches. Something just feels different. We also think about whether you've been exposed to any triggers recently. We want to make sure that, if you're going through a very stressful time, maybe that's the reason why, and we can address that specifically. Is the weather really terrible? Is it hurricane season? And right now you're in Florida, and, or along the Gulf Coast, and it's terrible weather for weeks and weeks on end. Could there be exposures like food, other triggers, head trauma, medication overuse? Your doctor's definitely going to want to say, so tell me, things have been getting worse the last few weeks. What have you been using? And if you've been using something even well beyond the last few weeks, a little bit more frequently and consistently using it a little bit more and a little bit more, that may be actually what is at play. So it's always important, before we even start to think about what we could do, we want to make sure, is this migraine or is this something else? So when we think about off-label and different kinds of treatments than you would normally use, we have to think about what we're treating. Are we specifically focusing on the pain aspect? Is it that there's a sleep problem that's maybe worsening everything also, or is that a component to what's going on? Is there severe nausea? Maybe there's anxiety and stress. Are your symptoms related maybe to vestibular migraine, vertigo, and dizziness? Maybe there's profound light sensitivity or potentially fatigue. And when we think about other ways of treating it, we're not necessarily treating the migraine symptoms directly. Sometimes we're treating some other things and some other aspects of it, in addition to some of the standard treatments that your doctor already has you on. So what are the categories of medications that we think about when we're talking about these, off-label alternative kinds of treatments? So when we think about pain, and this is a little bit of an overview of what we're going to get into, we'll get into all of these different, medications and treatments right now. So first of all, some people will use medical marijuana. Ketamine, you'll hear people talk about either via nasal spray or IV. LDN stands for low dose naltrexone. Minocycline is an antibiotic, which sounds kind of out of left field. Why would you use an antibiotic to treat migraine? Migraine is not a bacteria. Sometimes if people are experiencing insomnia symptoms, we may talk about using atypical antipsychotic medications, which may sound very scary. And we'll talk about, what the reason we might want to use that. In general, with nausea, we may also think about different kinds of antipsychotic medications, more along the lines of the typical antipsychotic medications. For anxiety, we may think about some antidepressants that are not SSRIs or SNRIs or TCAs, but totally different other things. For vertigo, actually, there's some people that are using things like eye drops, right? We have to think about some talk that people have about that specifically. For light sensitivity, there are lamps that people are using. And for fatigue, even people are using stimulants. Is there evidence, and what is it for using all of these different things? MMJ stands for medical marijuana. So it's a question that I think we all get very frequently, most headache specialists, most neurologists. And the question is, will medical marijuana help migraine? As you can see over here, this is a recent study that was published in Current Pain and Headache Reports. And the title is Cannabis and Migraine. It's complicated. And the truth is, it is complicated. Why is it so complicated? Well, it's complicated because there are currently no randomized controlled trials. And if you really want to know whether something works or not, you have to have a randomized, double-blind, placebo-controlled trial. You really want the highest standard. So how come there aren't any? Well, one problem that's pretty obvious is there are federal regulations against using the highest regulated medications and illicit drugs for even scientific studies. So it is complicated on a federal level. Even states that have the ability to use marijuana even recreationally, it's much more difficult to go and apply for a study and to have the proper license to prescribe or enroll patients in a study for things like medical marijuana than it is to go down to a dispensary and get it recreationally. Some of the other reasons why it's complicated is because there isn't necessarily a standard dosing regimen, right? Most of the time, if your doctor is recommending something, they'll say take it 20 milligrams 2 times a day or something like that. Well, what is that when we're talking about medical marijuana? There are so many different combinations of treatments. There are different active compounds when we talk about medical marijuana. So there's something called CBD, cannabidiol, there's THC. That's the more psychoactive component to it, which is actually working. We know that there are cannabidiol receptors in the brain, but some studies that looked specifically at cannabidiol, which can actually help some refractory seizures, actually don't seem to do much for migraine itself. The initial data for some medical marijuana studies that aren't randomized, but open label, seem to say that some degree of THC is necessary. On the other hand, is there a possibility of rebound? And the truth is, there is a likelihood that medication overuse headache can happen if you're using medical marijuana to treat headache acutely. And that's what we see over here. This is a colleague of mine, Dr. Nunu Zhang, and she reported, and I've seen this anecdotally as well, that if you do use medical marijuana, it is possible to start to develop a transformed kind of migraine, more frequent migraine, and medication overuse just because of that. So maybe that means that it is a good acute treatment. So there are a lot of question marks. Moving on to another treatment for pain specifically, we think sometimes about ketamine. Ketamine is also an illicit or street drug for many times. That being said, it's used now for refractory depression, and many pain centers will use it for a number of different indications for pain. There are a number of formulations that you'll see being used. So you may see your doctor recommend intranasal ketamine for an acute treatment. You may see a pain doctor or even an emergency department. And there are actually a number of emergency departments that have started to implement an IV ketamine protocol, even for acute migraine, which to me is very interesting. There isn't great data, and it's not something that was included in the most recent American Headache Society guidelines for treatment in the emergency department, but it's something that many EDs are starting to use now. And you may even see a few protocols for continuous infusion at major inpatient headache centers. Jefferson, for instance, has one. There are a couple around the country that also would have an IV continuous infusion for that. What would that look like? Continuous infusion usually is actually not run, even though you're admitted to the neurology service or the headache service. It's actually usually the anesthesia department that is in control of the actual pump. They start very low. It's adjusted to how sleepy you are and the degree of pain control. And it's typically given over the course of 5 days. They usually try to find a good steady state for you. Another option that some people may see recommended is something called low-dose naltrexone. What is naltrexone? It blocks a specific kind of pain receptor that narcotic opiate medications work on. It has been used for a number of other pain conditions. The evidence, honestly, for using it in migraine isn't very robust. Not much has been published on the use of low-dose naltrexone for migraine. Much more has been spoken about with regards to things like fibromyalgia, chronic fatigue disorder, other indications and other other diagnoses. It's actually used not at a low dose, but at a full dose for things like appetite suppression. And what is the low dose that we talk about? Well, it's pretty low. Usually it's given as a liquid. Usually it starts at not 1 milligram, not 0.1 milligram, but 0.01 milligram. So it's very low, and very slowly you increase it to 4 to 6 milligrams. And usually that's about the point where you go. The evidence that we have is a case report in patients who have both multiple sclerosis and migraine. Anecdotally, it's helpful. Anecdotally, it's very well tolerated. And I'll tell you, I do prescribe this sometimes for some of my refractory chronic migraine patients. And I will say that there are some people that do quite well and hadn't done well on anything else prior to this. Now, what is minocycline, right? I was saying, where in the world is this coming from? What's interesting about it is that minocycline is an antibiotic. You may have even seen minocycline being used by dermatologists, and it's not because they're trying to kill the bacteria in your skin that causes acne, but because they're actually trying to decrease inflammation. And minocycline does have effects on a specific inflammatory modulator called TNF-alpha. And there are not, there's no again, randomized controlled trial, like there isn't for just about any of these things, looking at the use of minocycline in migraine, but there are a number of case reports. Usually the dose is 50 milligrams twice a day, and if it's effective after a month, it's usually increased to 100 milligrams twice a day. That being said, there are always going to be concerns if you're using an antibiotic. Would this potentially lead to, long-term antibiotic resistance? Is this going to cause, issues with your gut long-term going forward? So what I would say is this is usually not something that we use forever. This is usually something that we would use for a few months at a time, not necessarily for much longer than that. For those reasons, we do often, not always, but if you do experience GI symptoms with it, we recommend then a probiotic. Other antibiotics are actually used for other headache disorders. We're focusing right now on migraine, but new daily persistent headache does have a protocol that some people like to use that was published by Dr. Todd Rosen of Mayo Jacksonville, of doxycycline, also 50 milligrams twice daily, in Singulair. Singulair is a child's asthma medicine. So here's the thing with regards to insomnia. A lot of times people can't sleep either because of migraine pain or because they are so debilitated during the day that they, really have a difficult time sleeping at night. What are other options and other things that can help that specific aspect? If we're looking at, you as a whole, we want to think about what are some of the ways to potentially break in and help migraine plus. So when it comes to insomnia, a lot of times patients may say, well, there are some really great sleeping pills I always hear about. There's, Ambien, Lunesta, but the problem is the class of medications that those sleeping pills are in. The class is called the hypnotic class. And the reason why is because you technically are asleep. You're not like doing something. You're not staring at the ceiling or looking at your alarm clock, but it's a very superficial sleep, almost like hypnosis, and it's not very good quality. There are sometimes some antihistamine type medications that your doctor may recommend. Hydroxyzine is a pretty potent antihistamine type medicine. There's really no evidence that it could specifically help migraine, although cyproheptadine is something that's very commonly used in two interesting situations with migraine. One is children who have migraine, and the other is oftentimes in pregnancy. It does actually have a very good safety rating, and there's great safety data with regards to using cyproheptadine in pregnancy. And sometimes in pregnancy, if you're not sleeping well and you have really bad migraine, we may consider using that specifically because it's very safe. We talked about atypical antipsychotic type medications, and sometimes these are used as a bridge or short-term preventive. What does that mean? That means that you would use it for a few days at a time, maybe a week, maybe 10 days to break a bad cycle. And oftentimes these can be very, very helpful when you're in more of that terrible status migrainosus side of things, more than the chronic migraine side of things. Olanzapine or Zyprexa, quetiapine will actually sometimes use even as a long-term preventive. So even though it can be helpful sometimes to break a bad cycle similar to olanzapine, they are related. We don't like to use olanzapine daily, but quetiapine can be used daily. Preventives. There's not a lot of, again, these are case reports. There's not a lot of evidence for the use of either Abilify, which is aripiprazole, or Latuda, which is another kind of novel kind really of antidepressant type medication. Though there are some case reports and presentations that have shown it to be helpful, and these are things that rarely, but sometimes I have used for and with good effect for some of my patients, and it can be sometimes added on very helpfully. Nausea. In general, when we think about nausea type medications, we think about neuroleptic type medications. Those are the Reglan, Compazine type medicines, and other ones that work more on serotonin rather than dopamine. So when we think about those neuroleptics, what are things that can also help? Most of us are familiar with Reglan, Compazine, and probably Phenergan or promethazine. So on that same spectrum, there are two that sometimes can be helpful, especially if the nausea is very severe, and that can be Haldol or haloperidol or Thorazine, which is also called chlorpromazine. They're very sedating. We usually don't like to give them to you for long periods of time consistently, but sometimes these will be added if you're admitted to the hospital in addition to a number of other treatments, again, to break the really bad cycle, more so than to use preventively or daily. Other anti-nausea type medications that are more on the Zofran side are Tigan, and Emend is another one also, although Tigan can right now be very difficult to get access to. When we think about anxiety or mood in general, most of us are familiar with the SSRI, SNRI antidepressants, and even if you're talking about medicines that we use for prevention of migraine traditionally, we're usually thinking of TCA medications also. That's like amitriptyline or nortriptyline or even protriptyline, which technically is a TCA. I didn't want to add that over here, but a lot of people haven't heard of that. But if you've done well but can't tolerate the other triptylines, that might be an option that could also, be added to this discussion. But each of these work a little differently. None of them, not a single one, has ever been studied, published, case reports at all for migraine. So this is not necessarily me saying that these things can do anything for migraine. There's no evidence to say that whatsoever. I will, however, say that many of my patients sometimes are on some of these medications, and sometimes adding that specifically in combination with maybe some of the other things that you're on can be very helpful. The nice thing about these more novel type antidepressants is that the majority of them, not all, but the majority can be used well with some of the other standard SSRI, SNRI type antidepressants without fear of serotonin syndrome, which is always the concern whenever you're mixing antidepressants. So some of them you might be more familiar with and some not. Bupropion or Wellbutrin is something, talking to some of the psychiatrists that are colleagues of mine who see or either inpatient or outpatient physicians at major headache centers. Wellbutrin may not necessarily have any evidence, but it can anecdotally, according to them, be effective. And I've also seen it be very helpful together sometimes with an SNRI. For instance, a combination of bupropion and Cymbalta can be very helpful, or even just an SSRI. It works on norepinephrine and dopamine. Remeron or mirtazapine, better for sleep. Then there's a number of these azidone type medicines that are a little bit more like the atypical antipsychotic family. Trintellix is a newer type medication. What's most interesting to me about Trintellix, if you look at the data and you look at how does it work, because for us, we want to know what's the method of action. Officially, it is a blocker of the same receptor that triptans work on, which is to me very interesting. So there's a specific serotonin receptor that officially this blocks. What I think is interesting is I've seen patients on it that have used triptans, and the triptans still seem to work. I think that there's still a lot that we don't know necessarily about how Trintellix works. I'm not the psychiatrist, but likely there are more, parts of its method of action to really try to understand how it works, because otherwise I think, it wouldn't really work well with a triptan, and theoretically it should worsen headaches significantly. So what do some people do with vertigo? And I apologize if the picture itself, is a bit of a trigger for some people. Hopefully it shouldn't be. And if it is, you can certainly dim the screen for just this little bit. Timolol eye drops is something that a lot of people are talking about online. And the truth is that there is not even a case report, it's a letter to the editor, that, and this is literally the entire letter, where somebody in 2004 talks about using timolol eye drops. So timolol is a beta blocker. It's a blood pressure type medicine that's very effective in preventing migraine. And oftentimes people will use it as a first line or second line medication orally. It's used as a treatment as an eye drop for certain types of glaucoma. And it's become very popular to use most recently for the vestibular migraine symptoms, although there isn't a lot of new data for it. It appears for the most part to be pretty well tolerated, with the exception of you might actually be a little bit more light sensitive if it does dilate your eyes, which it likely will do, at least a little bit. But otherwise, I personally, in my experience, again, I haven't used it for very many patients. I haven't seen it being that effective, but many people are using it. When we talk about sensitivity to light, there is actually great evidence for the use of Namenda in general for migraine. And many neurologists aren't even familiar with the use of Namenda or memantine for migraine prevention at all. There are actually 2 excellent randomized controlled trials that show its effectiveness just in general for migraine. When we talk about light sensitivity specifically, we do see that anecdotally, it can be effective in combination, usually with other medications. Sometimes if the main issue that still remains is light sensitivity, adding it on can be helpful. Green light therapy is actually very interesting to me. What is well established in the, really the ophthalmology literature is how we perceive light and what hurts and what doesn't. Because even if you don't have migraine, some light does tend to be more irritating than not. And certainly you know this if you have migraine. The blue spectrum of light, so when you're looking at those new LEDs, the white light is actually bluish. And that's the most irritating. Things that are in the greenish spectrum of light, oftentimes those are the kind of LED light bulbs that are a little bit more yellow, can be calming. And there are specific frequencies of light that are used for photophobia. And there's a specific kind of lamp actually that recently came out called the Alley lamp that was put out by part of the team that actually did most of the research in this blue versus green spectrum of light. What do we think about if sometimes the pain is maybe under somewhat better control or stable, and some of these other symptoms are remain stable, but you're still so fatigued. There's still so much that you just feel like you can't do. So what are options? So in general, we think about SNRI antidepressants in general for migraine. SSRIs don't seem to be very helpful at all for migraine. Sometimes we're lucky if an insurance company kind of uses it and for the process of prior authorization, but there's no reason for the most part to think that medicines like Lexapro or sertraline can really be that helpful in preventing migraine. The norepinephrine that's in the SNRIs like Cymbalta and Effexor does seem to be very helpful. Caffeine, we know, helps headaches acutely. We know that stimulants in general are somewhat vasoconstrictive. So there's reason to think in general that something that increases norepinephrine of the brain can also be helpful for migraine. So maybe using things like stimulants could also be helpful. The issue with stimulants, and some people may say, well, I actually had to get off my stimulant because it was worsening my migraine. I've heard that from many patients. Sometimes the reason why is because you may not always be using it consistently, for instance, at the same time. You may not be using it, let's say, on the weekends. Maybe you're only using it, let's say, for school or for work on the days that you're at work. One thing that we definitely know with regards to stimulants is that the more consistent that you are with them, the less likely they'll worsen migraine. And they probably won't be able to necessarily help directly, but there can be some additional benefit by adding it on to some of the other medications if the issue specifically is fatigue. Sometimes, because these are restricted medications mostly, oftentimes you'll have some pushback from many of the neurologists or headache specialists, and they'll say, listen, I don't prescribe a lot of stimulants, and they may want you to get that from your primary care doctor or psychiatrist instead. I've definitely, seen that, and there's concern on their end. What are some things to take away from this talk about a lot of different options and things that are off-label or kind of out of left field for migraine? Number one, I think this is the most important thing, is we always have to make sure that we know what we're treating. If you have had migraine for years, are you sure that you have migraine? If things are worsening, are we sure that it's as simple as this is migraine worsening and that there isn't something else potentially going on also? It's important to realize that using too much, sometimes, an effective treatment can cause more headaches long-term, and even medical marijuana, even if, let's say, anecdotally, you found it to be helpful, sometimes it can lead to rebound. And it's important to, know that and to recognize that. In general, I think it's best to think about non-traditional medications and off-label uses of traditional medications as an adjunct. I wouldn't necessarily say that for most people, using even something, let's say, like low-dose naltrexone, minocycline, that they're the most helpful alone. They're usually helpful in combination with other things that seem to have been somewhat helpful, but you just need something to kind of get you across the finish line or something to stabilize things even further. One other thing to think about is that the treatments that we're discussing are not all pills. Sometimes they're nasal sprays, sometimes they're even eye drops. It's interesting. So anyway, if anyone has any questions, please feel free to reach out.
Wonderful. Thank you so much for that incredibly informative talk. Before we get into those questions, actually, I did want to just mention one quick thing that was not on your list. And we did get questions about whether this would be on the list. And that was medical devices. And some people, they're not off-label, but they are lesser known. So I'm wondering, Dr. Berk, not to rain on your parade, but maybe sure, if you could take like 2 minutes just to explain maybe what they are and why they're so unknown and underused.
Mm-hmm. Absolutely. I totally agree with you. I didn't include them because they're on label, and I would say many people, especially in this community, are well aware of them, not necessarily everyone. So I was debating time-wise if I would have enough time to really go through them well, but we do sometimes use what we call neuromodulation, or these kinds of stimulator devices for different reasons. Usually the indication is migraine, although some of them have other approvals for indications also. In general, we think about devices that most people are probably familiar with, like the Cephaly, which is a neurostimulator, kind of like a TENS device that specifically stimulates nerves over the forehead, so the supraorbital and the supratrochlear nerve. It's actually available without a prescription, so you can just go to their website and buy it. And it works just like any other kind of TENS device. It's stimulating the nerves under the skin. So you might be familiar with that if you've ever done PT. They might put it on your shoulder, your neck, your low back. Another device that is sometimes used is the Neurivio device, which is a device that goes around the arm. It stimulates certain pain receptors in your arm that convinces your brain that there's pain that's occurring, even if it's not necessarily a painful stimulus. That's a device that can be used primarily acutely, although there is right now a preventive trial underway, and it's approved for adults and actually for teens. So 12 plus right now, the FDA has approved it. You do need a prescription for it. on average, you may need to replace it depending on how often you have migraines, maybe about once a month or so. And it's something that you could definitely ask your doctor to prescribe for you. The stimulation itself lasts usually about 45 minutes. Another device that some people use is called GammaCore, which is an external vagus nerve stimulator. So it's something that you would put up to your neck, and it would stimulate the nerve that's in charge of rest and relaxation for the central nervous system. That also has an indication for use in cluster headache. That is also, you need a prescription for that. And each device, I think, lasts a few months at a time, if I'm not mistaken. Used to only be 30 days. Another device that people use that the company went bankrupt, but now was bought by another company, and technically you can be prescribed this device again now. It is a single pulse. It's called a TMS, or transcranial magnetic stimulator. Some people might be familiar with TMS for things like depression, anxiety, and OCD. That oftentimes is done at a psychiatrist's office, and that's called repetitive TMS. This is single pulse, very effective, especially for migraine with aura, where it can really kind of knock away the aura. And it's, a few stimulations done kind of back to back. And that's usually something that's rented from the company for a few months at a time. It used to be called the Spring TMS. I think it has a different name right now, but I'm blanking on what the Savvy. Now it's called the Savvy. Thank you. I was trying to remember what it was rebranded as. And the last device that is yet to hit the market is somewhat similar to the Cephaly in that it's like a TENS device, but it stimulates not just those nerves in the front of the head, but also ones in the back of the head. And there's supposed to be a smart component to the app where you should be able to, it would know based on your history, how much to stimulate one area versus the other. So it stimulates both the supraorbital supratrochlear nerves and the occipital nerves. That's called the Relivian device. So that was actually approved by the FDA almost a year ago in the summer of 2021, and hopefully should be available sometime soon.
Right, absolutely. And I think my understanding for the Relivian, I know we get a lot of questions about that, is that it is available in a few headache centers, not all of them by any means. They're doing a relaunch. So I am definitely following that. So we will let people know when it is available, and I'm hoping to get it. So I'm staying on top of that news as well. So thank you so much for that. Sorry for putting you on the spot with that as well. It's always interesting that there are some things that are FDA approved, but they're not well known or not frequently used. And so those are some of the options. You can find out more information about the devices on my website. So one of the questions we have here, this is going to be a real quick answer, and I think I know the answer to it, is can NeuroHealth be accessed outside the US? My understanding is it's for the US and Canada, but not outside that. Is that correct?
So the answer is that's correct, with one exception, which is if you do have a United States phone number, there's a way to, we would still only be able to do what we call an educational appointment, which is where we wouldn't be able to prescribe any medications, but we can try to, give you some recommendations and things to do. And you can also follow us for coaching, for care plans that we have, and to use our tracker. But if you do have an American phone number, or if you know somebody that does, then you would be able to get into the system that way. So it is possible.
Okay, that's good to know. I know that we also had a lot of comments where people were asking about, making comments that there are medications and treatments that are specifically designed for migraine. We do know that, but for some people, they don't respond to them, or they're not able to tolerate them. And so, as Dr. Berk said, these are some of the options that you may want to consider and talk to your doctor about in those cases. So we had a couple of questions that are very similar. One is, what should we do if our doctor isn't willing to consider these alternative treatment options? And then the follow-up question for this, which is much more challenging, is how do we get the insurance companies to understand the off-label use of these type of meds and treatment options and get them covered?
Absolutely. The one thing that I would say about, how do you get your doctor to know? If your doctor is not a headache specialist and you have very refractory chronic migraine, you probably need to see somebody who really is, a board certified fellowship trained headache specialist. And those headache specialists should know many of these other off-label options and off-label treatments. That's really what you go to fellowship for, not just to be able to give Topamax to people who have migraine 3 times a month, but for the understanding of what can help in some of these more difficult situations. And I would definitely say, if your doctor isn't familiar or says, what are you talking about using low dose naltrexone, I think that it might be worth seeking out the care of a headache specialist specifically. With regards to insurance approval, what's interesting is that the majority of these treatments don't have a lot. First of all, almost all of them are not expensive. Even though they're off-label, usually it isn't a problem getting them approved because they're generic, or they might be compounded by a compounding pharmacy, and usually the cost even then isn't really isn't much even out of pocket. Usually there is some coverage for compounded medications in your drug prescription drug benefit. The one interesting thing that I've found for some people is using Namenda if you're under 40 years old. I've seen some insurances across the board just deny it, unless there's a diagnosis of like a rapidly progressive dementia or something like that. So that would be maybe one of the few examples where but even I would say some of the atypical antipsychotics, even many of the newer or novel antidepressants, I would say maybe with the exception of like vilazodone, which is Vibrid, and the Trintellix, those are like really new, and those are still branded and not generic. Just about everything else over here should actually have fairly standard coverage.
Right. And that's really interesting to know. And I think that that's where it comes to actually speaking to a doctor who either is aware of these options or who's willing to at least consider and research them. And one of the things I like about NeuroHealth in specific is that you will, even if someone is not, if you're not licensed in their particular state and can't prescribe, then you'll do that consultation with them, and you're happy to work with their doctor to try to talk to them and see if they're willing to prescribe those medications. So that is an option for people as well. I will say that one of the things I personally most like about NeuroHealth is their approach to prior authorizations. Most people here know that prior authorizations and the formulary exceptions are a total nightmare. Many of our doctors just say it's not going to get approved, or it's going to be too difficult, or they just don't do the paperwork because it's a lot. But NeuroHealth is fabulous at this. So just want to give you a heads up that is a huge plus, and also to encourage people that there's never no hope. And Dr. Berk says this to me all the time. We haven't explored everything because there are so many other options out there that we can look at. So I know that we had one quick question about low dose naltrexone. Maybe you can just clarify this. So obviously there's a difference between low dose naltrexone, or LDN as we often call it, and naltrexone itself. So the larger dose of naltrexone is used to help people who have overdosed, right, or get them off opioids, is my understanding, but LDN is different. Maybe you can just clarify that because we had a question about it.
Absolutely. There are definitely some people that will also use the higher dose naltrexone for other indications. And it's actually, one interesting thing is there's a pill that was approved by the FDA. I'm going to say maybe it was about 5 years ago now. That's a combination of Wellbutrin and naltrexone that's specifically meant, and both of those at full doses for appetite suppression and weight loss specifically. I forgot the name of it, but oftentimes, because both of these are available generically, doctor might not necessarily prescribe that one pill that has them both combined, but we'll give you 2 separate pills for better coverage. The evidence for use of low-dose naltrexone really comes from, like I was saying, the fibromyalgia and chronic fatigue literature, and some other chronic pain cases and trials. So that's really where it comes from. And there does seem to be some potential benefit at low dose. The benefit also would definitely be better tolerance. So if nausea or sometimes jitteriness is an issue at the higher doses, this is potentially a way of using it at low dose, and it can be better tolerated that way. I will say that there are some doctors that'll say, right, the more the merrier, and it's sometimes, let's say it's complicated, or you can't find a good compounding pharmacy close to you. Most pharmacies will be able to prescribe the regular 50 milligrams, and they'll say, just try it and see. So I wouldn't say that everybody exclusively recommends low dose naltrexone. That's, I would say, what most people are recommending based on that data.
Absolutely. And one of the things I found interesting from your talk and many of those treatment options is that a lot of those are used for other conditions, or they're all used for other conditions, obviously, but a lot of those conditions are comorbid with migraine. So a great example of that would be singular. If you have asthma, you can double up. And then LDN, increasingly a lot of rheumatologists prescribe that for inflammatory arthritis or fibromyalgia, which of course is heavily comorbid with migraine. So if that's appropriate for you, you may be able to kill two birds with one stone, right?
100%.
Yeah, which is obviously, a great thing if you can do that. Speaking about that, a question that just came in is asking, are there any treatments that you would like, what treatments would you go to first to break like a constant migraine or constant headache, like a refractory headache that just does not go away? Where would you start in that big list of options?
Mm-hmm. When we think about headache that doesn't go away, let's take, for example, what this sounds like is more status migrainosis. That's what it sounds like, more than let's say chronic migraine. So you're somebody who maybe has had migraine for years. You try your sumatriptan and it's not working. You try it again and it's not working, and then you're a little lost. And then you say to yourself, "Oh no, what do I do now?" Oftentimes, when you do see a headache specialist, they'll usually talk to you about what to do, and they'll usually give you somewhat of an acute treatment plan, like an attack plan, what to do if the pain is, like this, or what to try first, etc. And there usually is a first-line acute medicine, which is usually something that's more specific for migraine, where we would think about it as a triptan or a GPAT, like the Ubrelvy Nurtec type medicines. And sometimes what we'll say to add on would be, if you're still not doing well, a stronger kind of anti-inflammatory, like naproxen, which over the counter is Aleve, usually using that. 2 pills, which would be the full dose, obviously taking it with food and a tall glass of water to protect your stomach. And if this is going on beyond 72 hours now, usually what your doctor is going to recommend is one of probably 2 options. One would be a steroid to break a bad cycle. The other would be, if you hadn't used, let's say naproxen, a different kind of stronger anti-inflammatory type medication. That might be flurbiprofen, that might be nubumetone, that might be the new, celecoxib that has recently come out, that some people are now using also, that has some evidence for quick use in migraine. If this also isn't effective, sometimes what we think about is a second short course of medications, which might be more along the anti-nausea or atypical antipsychotic family of medications. So that might be that, Zyprexa or Seroquel bridge that we talked about, using something like that for maybe a week to 10 days at a time, or sometimes using Raglan or Compazine regularly. Some people will even at that point bring in and they'll prescribe the Haldol or the Thorazine, especially if there's a lot of insomnia. That might be an option that some people would say, again, not to be used consistently, but in a short period of time to break it up. And if you're still not doing well, that's where we start to think about maybe going into the office for nerve blocks, where we would think about maybe IV medications at that point. And obviously the entire time, your doctor is going to be asking you, what do you think triggered it? Do you think something happened? Does this feel different than your typical migraine? And if there really is something that triggered it, focusing on that. If it feels very different, obviously we want to make sure that we're not missing something. And that may even mean that your doctor would say, I want to examine you. Let's do something face-to-face. If we can, even telehealth, right? We can do a virtual exam at a minimum. And maybe your doctor may recommend new blood tests. Maybe they may say, you know what, it's been 3 years since your last MRI, and some of these symptoms you've never had before. Let's see if we can get an MRI quickly. So that's usually along the lines of what we would consider in that situation.
So that's a lot of options. So if any of you are in that situation, please don't give up hope. There are just so many variations that you can use when you're seeing a doctor who is creative, who's willing to think outside the box. We have time for, I think, 3 more questions. We started a few minutes late, so we're just going to go an extra couple of minutes, if that's okay with you, Dr. Berk. So the first question was talking about nerve blocks. Unless I missed it, did you cover the use of SPG blocks for preventive and acute treatment?
So I actually did not talk about the use of nerve blocks or SPG blocks specifically, and that can be something that's very helpful for many people. I was specifically focusing on medications, but yes, absolutely. It would be something that would be done at the doctor's office. Usually it's done with a specific kind of device. There are a number of devices that people use now for SPG blocks. Probably the most commonly used one is called a TX360, but there's also sphenocath, and there are 2 or 3 others. And usually it's done with a delayed kind of lidocaine that's called bupivacaine. It's not really an injection with a needle, but it's a squirt basically to the back of the nose where this large bundle of nerves is. And if it's unilateral pain, we would only do it on one side. Otherwise, we would do it bilaterally. It's usually very effective consistently. The best evidence for use is twice a week for 5 weeks, although that's very difficult for most patients and even most doctors to schedule in a busy doctor's office. And sometimes there are adjustments in that schedule. But if you've done it 2 or 3 times and it's not that helpful, then sometimes we'll move on to do something else.
Right, absolutely. And I mentioned that just because that was something that you mentioned to me, and for people to know, I have an SPG block every 3 weeks. It works really well. If people are nervous about having it up their nose and you've had a COVID test or one of the older COVID tests that felt like, the Q-tip was tickling your brain, it's not as uncomfortable and painful as that, that's for sure. And it's not as painful as having the occipital or trigeminal nerve blocks either. And it could be effective for you. So that may be worthwhile talking with your doctor about. Here's a quick question about nasal spray oxytocin. And I don't know where that is in clinical trials, if it's preclinical or is that used as a daily preventive?
I've seen people use it. There's not a lot of evidence for its use, which is why I didn't really bring it up. I've definitely seen its use sometimes. I'm not even that familiar right now for indications of use when the people that do prescribe it like to prescribe it and when they hold off on using it. So that's why, just because it's something that I've literally never prescribed in my life, I really kind of held off on talking about.
Sure, absolutely. And I appreciate you saying that. So yeah, thank you. We get a lot of questions about things that are sometimes very unusual. That's one of the less unusual ones, but we do get unusual questions in our group, so it's good to have an answer. One quick question here is, and I think this is going to be the last question, is specifically for vestibular migraine. We have a lot of people in our groups who have vestibular migraine. Which of those options that you covered would you go to, as a first line to help relieve the dizziness and the vertigo that comes with that?
I would say for most people, the best treatments for vestibular migraine are the best treatments for migraine. Usually, that can be, the same kinds of first-line treatments. For instance, using, SNRI medications, using calcium channel blockers. Some people will use lamotrigine, Lamictal. The problem is it can take a long time before you get up to a good dose. That's an anti-seizure type medication. In general, we like to use things oftentimes plus vestibular therapy if the patient can tolerate it, because non-medical treatments can go very far. But that's what I would say would be my first line treatments. the same kinds of first-line treatments that most people would use initially for migraine itself.
That's really helpful. Thank you so much. So before we close, any final thoughts, Dr. Berk, on this topic?
You definitely want to make sure that your doctor is somebody who keeps their mind open and does not say to you, you know what, you're just going to have to deal with it.
And that's so sad when we hear that. I saw someone made a post yesterday that their doctor was basically saying, just deal with it. And that's so sad, and it's not okay. So thank you so much, Dr. Berk, for being with us here again today on Migraine Meanderings. For everybody else, thank you for joining us. I hope that you found it helpful. If you have any comments or questions that have not been answered in this live event, then please come to Migraine Meanderings on the first Wednesday of the month. Ask your questions in the Doctors in the House, or you can also try NeuroHealth for yourself. And I know that that will be beneficial for people. Again, please don't forget to use the discount code MigraineM15. And we wish everybody well. Please partner with your doctors. And thank you so much for joining us today.